Hi, welcome to this special meeting of the Senate Health and Human Services Finance and Policy Committee. Earlier this week, the Minnesota Department of Health rolled out phase one of their testing plan, and press conferences are a hard place to get into details. I know this group had just recently had an overview of the capabilities of testing in some of our key healthcare systems, so Mayo, the University of Minnesota, and Hennepin Healthcare. But now that the plan is starting to have some structure to it, I appreciate very much that MDH has made Mr. Huff available to us again. We're going to, when Commissioner Malcolm becomes available, we'll interrupt the regular proceedings and welcome her for comments and questions. And then Commissioner Franz will be joining us at the very end. Contracts are under MMB, and I believe Ms. Strand made the contract available to you at the top of your inbox if you have any questions about that. I believe Mr. Colleen from the University of Minnesota is here with us as well and can talk a little bit about the university's role. After we finish up with Commissioner Malcolm, we'll have him on the agenda. So Mr. Huff, if you could please start with a walkthrough of what our current understanding is of phase one and what plans moving forward might look like. Welcome to the committee and please proceed.
Thank you, Madam Chair. Good morning, Senators. When we talked last, I was able to go over our goals, but not with a lot of definition of how we were looking on achieving those goals. So hopefully we'll be able to answer some of the questions you raised at the last committee hearing, and then any other questions that you may have since then. So I just wanted to review real quickly the goals that we have outlined as part of our testing strategy. And that goal number one is that we test all folks in Minnesota that have symptoms, that we're able to test folks that have a need from a clinical perspective, that their doctor is saying, hey, we need to test you before a procedure or we're giving birth, something like that. And that we continue to support supply procurement throughout the system, and that we are able to centralize our communications. We also want to make sure that we're testing communities of color, focused testing in communities of color, focused testing in our vulnerable populations, such as those in long-term care, or other congregate settings, such as prisons, and people experiencing homelessness. And then we also want to make sure we have focused testing the staff serving those populations so that they know that they are covered and protected, including, and then we want to make sure we're testing critical infrastructure workers. So food workers, childcare workers, transportation workers, utility workers, those folks who we depend upon to make sure that our society is running. We want to follow up with case investigation and contact tracing of all of the folks that have been tested positive, make sure that we are using that effective tool to slow the curve and slow development as we begin to lose on some of our community mitigation standards and slowly return back to work. And then we also want to have a statewide surveillance system that allows us to see how fast, if we go back to my truck analogy on the hill, how fast we're going down the hill and how far down the hill we are. So I'll talk about how this plan begins this and the next steps we plan on taking. So you've had a chance probably to see this, but I wanted to just walk through. So the first thing, and I think this gets to Senator Jensen's question the last time we met, of we need a centralized coordination of testing in the state. And so the first thing that is happening is we're establishing a COVID-19 testing command center. And this will be led by the university, by Mayo, and by MDH. And we'll have members of all of the healthcare groups, major healthcare groups, as well as other necessary folks, so that we make sure that testing is done in a coordinated fashion A lot of this is logistics. I need to get tested, or rather, I'm a clinician and I need access to testing kits and a place to send it. This command center will help answer those questions and make sure that the logistics are fulfilled of getting those test kits to the clinician and then getting them back from the clinician to the lab. Um, we're also going to be, as part of this contract, the ability to manage hotspot sample collection. So if we have a hotspot outbreak somewhere in the state that normal healthcare just doesn't have the resources to cover, then we'll be able to deploy folks from Mayo or from the University of Minnesota Medical School to go and be able to take samples and get these processed. A lot of this is going to be that logistical infrastructure. I think getting back again to what Senator Jensen raised, to make sure that the needs of healthcare professionals are met, um, as far as, how do they get the test kits and how do they send them back in. We are going to, as part of this, the U and Mayo are immediately ramping up the number of tests they have available. So one of the issues that we had in the system was we were in a scarcity model because we had significant shortages of supplies. And when we have shortages of supplies, it makes us much more conservative in use of those. And so we had healthcare systems who were rationing their supplies to make sure that they could meet their most immediate needs. What we've done here is opening up that supply warehouse, if you will, so that we no longer have to fear rationing, the fear of running out of test capacity. By Mayo and the U immediately ramping up their test capacity, we now will have, we're encouraging each healthcare system to continue to fully utilize their in-house capacity while we support them in supply chain procurement, but know that they have a relief valve that anything that exceeds their own internal capacity, they will be able to send to the U or Mayo, and that command center will help coordinate the logistics of that. We also are going to be developing, in order to really provide the public health needs and to make sure that we're doing a good job of reaching people throughout the state. We'll be having a centralized database that will be housed by the U and Mayo. Now, this will be a HIPAA compliant, confidential database. We're not collecting DNA. What we're doing is we're collecting just the test results, the serologic and the molecular or PCR test results, whatever demographic information people voluntarily share, and then other information, the clinical information, so that we can begin to get a better understanding of this disease, of its epidemiology. One of the advantages of this agreement and what it unleashes for us is the collective power, brain power, analytical power of the University of Minnesota Medical School, Mayo Clinic, and MDH to really tackle this issue of understanding this disease and how it spreads. Part of this will be a serial prevalence study that the U will be doing on a discarded blood from blood banks. Now, this will give us our first idea of how many people, now this is a limited population because it's people who donate blood, but how many people who did donate blood had already had the virus. That'll give us an idea, because we do know that asymptomatic people get the virus and recover, and we're none the wiser. So this gives us an idea of that a prevalence of how many people have actually had it. and we'll be doing more. Um, we'll really dig into that with additional research from partner with this partnership. And we're also one of the real advantages of this is the cost. We were able to significantly reduce the cost of testing. Um, Originally, molecular tests or PCR tests at Mayo were $99. Now that's been dropped down to $62 per test. And you can see that the serologic tests are $33 per test. So significant price reduction throughout Minnesota for accessing these tests. Now, some things are not covered in this plan, and this is what we're going to be continuing to develop. And we'll be working with you as we develop this. Now, there's going to be questions on funding. What we hope to do with all of this is to use federal funding first. And I'm sure Commissioner Franz will talk about how we think a lot of the costs, even in this contract, will be reimbursed through the federal government. But some of the things that you see that are not on here yet um, are uh, how are we doing our support for the building capacity in healthcare right now? So we do have, I think I mentioned this at our last meeting, we do have a supply manager who is working diligently tracking down supplies that are needed from the various hospital systems. Yesterday, Be the Match donated 35,000 swabs to the state. And we're working right now with healthcare to get these out to them, making the modifications that need to be made and sterilizing them. So that's the job of our supply manager, is taking these donations and whatever we can procure and making sure they're available for in-house labs. Um, we also need to begin to look at our focus testing. So this will be partnering with folks such as Hennepin Healthcare, our FQHCs, local public health, as to how we get out into the community and do testing for people experiencing homelessness. How do we test hotspots within long-term care? How do we ensure that people of color that we know have, because of existing health disparities, we're seeing a higher severity of disease nationwide? How are we doing more focused testing in those communities? That has to be worked out, and that's I guess sort of our step two, or the next steps we're taking. Likewise, doing focus testing in these critical infrastructure areas of both food production and food retail, such as grocery store workers or transportation workers, whether it be an engineer or a Metro Transit bus driver, our um, utility workers, making sure that these folks are tested so that they are not infecting their coworkers, so we don't have any of those important parts of our system going down. This I think became readily apparent as to how much we need this with the JBS closure out in Worthington. So we're working closely with local public health and Sanford Health and Mayo to make sure that people are tested out at JBS. But we want to get ahead of those kind of issues, which we hope to do as we stand this testing up. Case investigation. Now that's going to be a big piece. So if we go back to my analogy of going down the mountain, if our stay-at-home orders are the brakes, case investigation and contact tracing is like putting the truck into low gear. We're going to be moving, but we want to have a way to keep us from going too fast. We are going to have to significantly ramp up the number of people we have doing case investigation. The Star Tribune a couple months ago referred to our epidemiologist at MDH as the public health equivalent of a well-armed Navy SEAL team, which I think is quite appropriate considering the level of expertise that group brings. We're going to be moving beyond the special forces operation, and now we need to move into infantry operations, if I continue that metaphor. That means we're going to be hiring a lot more people. Our estimates, preliminary estimates, maybe 400 or 500 additional people doing these investigations. Now, these estimates depend upon what's the prevalence of the disease. That's based upon 10% of our tests being positive, doing 20,000 tests a day. We know that as the disease progresses, we may have higher positivity rate. We're actually closer to 5% positivity rate right now. So that may change. What we're doing now is, instead of just hiring a bunch of folks, we're looking at how do we redeploy other staff within MDH? How do we partner with the School of Public Health for students who need to have their clinical practice? And quite frankly, it's very difficult to do, and everything is shut down. And how do we work with our partners in local public health to achieve this? So we don't have the financials of that yet, but we're working on that because we know we need to get that to you. But we also believe that that may be covered with some of the funding we're receiving from the federal government for our response. And then that last thing is our statewide surveillance. How are we using all of these data to better understand, to give us those headlights on the truck as we go down the mountain? And that is going to be a partnership between MDH, the university, and Mayo Clinic, making sure that we're bringing some of the best minds in the state to bear on giving us light as we go down this mountain. So with that, I'll turn it back to you, Madam Chair.
Thank you, Mr. Huff. And members, we're going to do the raise hand. Sorry, I'm getting a little feedback here. I don't want to be irritating. So we're going to use the raise hand or the chat feature, and Ms. Strand will update me when you have a question. So Mr. Huff, you mentioned the 500 possible full-time equivalents. So is that included in this contract? Will that be a separate request?
Madam Chair, that is not included in this contract. That is part of this next phase, and it may be a separate request. It may be funded through existing funding or through additional funding that we're receiving through the federal government. But we will, once we figure it out, make sure that you know how we're doing it.
So I have Senator Kiffmeyer, then Senator Abler. So Senator Kiffmeyer.
Thank you, Madam Chair. Glad to be with you today. And so I just wanted to mention that I have 3 questions here. One of them is in regards to Mayo and University of Minnesota. HCMC is quite concerned that they aren't part of that. I know that was more of an agreement between the other two. Their question is about what is their status in this whole thing, and they've actually been very good with testing. Another one is on the charts for the committee today. We have some additional charts. One of them, or 2 of them, the y-axis has more of a stable increase to it, and then a measurement from that. The ones that we get from MDH have an escalating y-axis or gradual. It just makes it a little bit less clear on the picture of what's happening. If you could take a look at those and give me your comments. And then my third one is in regards to the codes, in regards to calling something a COVID death. I hear from my constituents quite often since they've become aware that people are being designated on the death certificate, families whose members have had cancer, were in hospice, and yet because they got COVID right at the end, it's being certified that it was a death due to COVID, when the family says for family history and other things, cancer is what really was. And as we know, as I know as a nurse, many hospice patients, pneumonia type situations, when they're at that stage, pneumonia will be frequently the last thing that they cannot sustain. So if you could respond to those 3 things, thank you.
And Senator Kiffmeyer, I'm going to have you repeat them kind of one at a time. I'll keep coming back to you, but so the first one I think was based on charts, and I don't know if those were made available to the committee to review. Oh, they're on the hearing notice and should be in the inbox. So I'm going to have to hop over to the hearing notice. But Senator Kiffmeyer, you and I had talked about the chart. So maybe Mr. Huff has seen them.
Madam Chair, Senator Kiffmeyer, I do not have those charts. But if where can I find those? Because I want to make sure I can answer the questions the best I can.
Ms. Strand, could you forward those directly to Mr. Huff so that we don't have to try to guide him to the hearing website?
Sure, yeah, I can do that right now.
That would be great. So Senator Kiffmeyer, maybe we could go to one of your other questions while we're waiting for that transmission.
Sure, that would be great. I think the maybe a little bit easier one is the HCMC connection with testing. They're concerned that they may be kind of not included, left out. I don't want to put words in their mouth. I was just on a call with them and they expressed concern about how they're going to be part of this total look and the central command and all of that. So if you could just in general touch on that.
And Mr. Huff, why was HCMC not included? I think might be given that they were part of the conversation earlier, it'd be appreciated to have some clarity.
Thank you, Madam Chair. Senator Kiffmeyer, you're right. This agreement was just between the university and Mayo. You know, one of the things about an agreement like this is using when we need to ramp up to 20,000 tests a day estimated would be what we estimate we may need. The university and Mayo have probably the highest ability to meet that demand. Now, independent healthcare is probably one of the highest lab capacities outside of the university and Mayo within the state. They are definitely part of this. As we now move to sort of these next phases or next steps in this process, a hospital like Hennepin Healthcare is going to be crucial. Their relationships in working with so many communities, especially communities that are marginalized or vulnerable for other reasons, working with them will be key. We're going to continue to build the capacity and support the capacity of statewide healthcare systems, including Hennepin Health. Hennepin Health will be included at the command center, as will the other large healthcare groups. But we will definitely be working with Hennepin Healthcare as we dive into this next phase of how are we reaching these vulnerable populations. Likewise with our FQHCs and other community-based organizations.
Okay, Senator Kiffmeyer, to your next question. Mr. Huff, do you have the charts that Senator Kiffmeyer was talking about? So, members, on the hearing notice, there are two charts, a 19-state comparison through April 13th. One has a 0 through 1,000 y-axis, and the other has -10 through 150 cases per 100,000 people. So Senator Kiffmeyer, those are the charts you wanted us to be reviewing? Yes, and Senator Kiffmeyer?
Yes, thank you very much. Okay, thank you very much, Madam Chair. So I have both the MDH chart and the y-axis goes 0 to 2, 0 to 5, 1 to 5, 10, so on up to 1,000. The other charts that were submitted to me, folks did some work, have a steady gradient. So it starts at the -10 and then 10, 30, 50. So you see kind of a ready, steady progression. And you will see, Mr. Huff, that it will demonstrate the status of where Minnesota is in comparison to other states on a solid y-axis. I think you get a little bit better picture. And matter of fact, there are actually two charts. The second chart that goes to 1,000 starts at 0 and goes up 100. Each step is an additional 100 on a regular basis. And again, reflecting where Minnesota is on that chart as compared to some of these other states, I think is a more of an accurate representation than the chart that comes out and the y-axis has a variety. Like at one point it goes from 500 to 1,000, which is a huge jump. So I just think that it would be very helpful to use charts that have a consistent y and a consistent axis so that the measurements that are relative in this regard would be more accurate, I think, and a little bit more helpful to us as we took a look. I just assumed they were because that is normal and customary. Do you want to make any comment, Mr. Huff? I wanted to call your attention to them and give you a little time to look at them.
And Senator Kiffmeyer, I think it might be good to forward that to MDH so that they can perhaps answer more directly why they would use an inconsistent y-axis. Did you have a third question? Because we're expecting the commissioner here any minute, and I have a couple of other folks. So you had one more question, I believe, for Mr. Huff.
Yes, I did, Senator Benson. And again, this one has to do with how deaths are coded, attributed to COVID. So the example of a constituent of mine whose parent was in hospice already and was in hospice due to a very severe case of cancer, didn't expect to be living very long, then got COVID, but on the death certificate, it did not reference the cancer. It would have been, of course, appropriate to say contributing factor COVID, as contributing factor could be pneumonia or the flu or other things, but the real reason for the death was cancer, and they were very, very concerned about their family history, their medical history, and it made them wonder and distrust the rest of the coded COVID deaths, whether they're actually COVID caused or if they were a contributing factor. So again, Mr. Huff, if you aren't ready to comment right now, I certainly understand, and maybe this could be an agenda item. If you have something, great. If not, maybe Senator Benson, we could have a different kind of discussion, or maybe Senator Jensen would like to comment on it as well.
And Senator Kiffmeyer, I think the death certificate issue is something worthy of raising perhaps with the commissioner. I haven't seen her jump on yet. So respectfully, Senator Kiffmeyer, I'm going to hop to Senator Abler and then Senator Rosen.
Absolutely, Madam Chair.
Thanks, Mary.
Absolutely. Thank you.
Senator Abler.
Thank you, Madam Chair, and I appreciate the time. I'll just limit myself to one question for now, although you know I have a lot. And the death certificate thing actually seems very important to me as a topic we would like to address. It does seem somewhat, I don't know, vaporous or something, and inaccurate. But anyway, my question, Mr. Huff, last time we chatted, you had said that there were over 5,000 or 6,000 tests that could be done a day, even today. So I'm curious about the today part. And there was one thing that I wasn't clear about, that you can do 5,000, they can do 1,000, or whichever order it was. Did I understand that they have the capacity to do it, but there weren't enough reagents and all those swabs, or is there currently enough materials to do the tests and they can do them today?
Oh, Mr. Huff, the question is, if we have 5,000, is the slowdown the reagents or other capacity, the swabs, et cetera? If we can do 5,000 a day, why aren't we doing them?
Madam Chair, Senator Abler, yeah, so I think it goes to, so yes, we have that capacity right now in this system, but we are in a scarcity model, and without a because we know that there have been supply chain shortages. And let me see if I can maybe do an analogy. So, you know, we had shortages of toilet paper, so everybody started hoarding. And it's sort of like the grocery stores would only put a little bit on the shelf at a time. Well, we just opened up the warehouse. So now the grocery stores can go ahead and put out what they have in their back stock room, their whole supply, knowing they'll get more. So even though healthcare systems, so hospitals had testing capacity, they were rationing that testing capacity because they didn't want to run out, you know, in 2 weeks. What we've now done is we've opened the warehouse and guaranteed that if you run out, we now have a ready supply source for you. So go ahead and use what you have.
So, Madam Chair, just to follow up on the same topic,
Senator
if I
Abler.
may. So this is distressing to me. Actually, the governor has called for 5,000 tests a day. Many stores and my Main Street discussions, which people have heard many times about, many very safe stores that could easily follow the guidelines and keep themselves from financial catastrophe, could open. It seems like if there were these 5,000 tests that could help us find the people who were really sick. And so it seems to me it's a logistical problem and a central control thing. And I hope that at the earliest, I know that this other large testing thing is 3 weeks out, it sounds like. But we need to get those other ones going today. And a governor who can, with a stroke of a pen, change the behavior of a state should be able to change the behaviors of all these health systems who are hanging on to these products that are really a matter of life and death and the financial health of our state. So, Mr. Huff, you can reply if you like, and then I'm done, Madam Chair. Thank you.
And Mr. Huff, so I guess the question is, there was this big announcement, what capacity is available today, and then what capacity and why the delay, I think is Senator Abler's concern.
Madam Chair, Senator Abler, so we have already seen an increase in utilization. So a few days ago, we had 800 tests performed. Yesterday, we had over 2,200 tests performed statewide. So we're having a dramatic increase in the number of tests being performed. You know, there a lot of tools that would have been available, you know, as you said, you know, that the governor could have employed. What we're doing though is we're hitting at the heart of the issue, which is opening up the supplies and capacity needs. And we believe that this agreement will solve this. And in fact, we're already seeing evidence that it's doing that.
Okay.
Okay.
Thank you.
And then next, Senator Rosen, then Senator Franzen, with the caveat that when the commissioner is available, you're going to get slid back, both of you. So Senator Rosen.
Thank you, Madam Chair. Mr. Huff, just a couple easy questions here. You mentioned the molecular was $99 and now $62. You never said what the other test was, the serologic test was previous, and now it's $33. And my other question is, when are these testing kits going to be available for our rural hospitals?
Mr. Huff?
I do not know the price of the serologic, or Madam Chair, Senator Franzen, I do not know, or Rosen, I do not know the cost of the serologic test. And as far as when will these test kits be available, rural hospitals can contact Mayo Lab now and have those sent out for them. What we don't have is that centralized command center for them to work through. But I know that Mayo can work with them today. I don't know if anyone from Mayo is on the hearing today.
Madam Chair, Mr. Huff, I would like to know that the cost of that serologic test previous, and probably a little more information at some point about the centralized database. Thank you.
Thank you, Senator Rosen. Senator Franzen.
Thank you, Madam Chair, and I apologize for coming in late. I had a conflict, but I'm not sure if you covered this before in terms of the rollout of this governor's testing initiative. But as it gets up to scale, which I've heard it's going to take days, maybe up to 5 days or more to just get to where we want to do in terms of capacity. How are we? I'm getting a lot of emails from businesses, including in my district, that want to know how do they get their employees tested before they start going to work. I've heard that there's a pilot or some businesses that are working with the state kind of a test run. Can you talk about that? Because I have not heard from anyone specifically on what that looks like and how we're going to open up, and how do we prioritize some of these businesses as they open up in this pilot program, if you will.
So, and Mr. Huff, so the 5-day question, because I hadn't heard 5 days. So if it is 5 days, that would be excellent news. And I have the same question, Senator Franzen, about how ambulatory surgery centers and dentist office can get access when they're not in the priority population. So Mr. Huff, I think there might be a broader question there, not just businesses, but also some of our healthcare providers who are waiting to safely open because of testing.
Madam Chair, Senator Franzen, I'm not aware of the pilot program you're discussing. I'll have to get back to you on that. So right now, our priorities are to test all symptomatic patients, to test folks for clinical reasons. What is the doctor recommending they need to be tested for before procedure, et cetera. And then focused on these targeted populations, which includes some of our critical infrastructure workers. We have almost 6 million Minnesotans, and we're opening up our capacity to be probably one of the highest per capita of the nation. But still, we're aiming for 20,000 people a day. It's going to take us a while to get through everyone, and some people have to be tested multiple times. So just because we're opening up testing doesn't mean that everyone all of a sudden gets to go back to work. We're still phasing that, as the governor's announcement yesterday, doing a phased approach to allowing people to go back to work, because we're still on this hill and we still have to get down this hill. And testing is a part of that strategy, but it's not the panacea. It doesn't mean you can just let off the brake all at once. We have to see how that low gear contact tracing is going to help slow us down. So it's I don't want us to be under the impression that just because we've expanded testing, all we have to do is test employees and then we can all go back to work, because it's more complicated.
Senator Franzen?
That's my point. There's smaller businesses of a handful of people that could potentially safely distance, and if they don't have symptoms, I mean, a lot of people are saying you can be negative one day and 24 hours later you can be positive. So we're going to start ramping up businesses to come in. I'm speaking, for instance, a company of about 75 employees. A few of their families might have had a fever, and they're starting to plan to come to work back and phase it in as well. But if they don't know if those employees are safe, they can't take the risk, obviously. But they want to know how do they test those employees that might have been have symptoms and want to return to work. So those are just basic questions. I know you're going to get there, but just to keep in mind when businesses are thinking of coming back to work, that they are trying to follow guidance, but at the same time they also have to have some direction of how they would be able to open up and in phases as well. So just an example in my district, and I don't think it's an official pilot program. I just heard that this particular business is reaching out to the state to be one of the first that could take advantage of this testing initiative to be able to start going in phases back to work physically. Thank you.
And thank you. And Mr. Huff, I just want to be clear, there's nothing in this contract that would preclude a healthcare entity from working with, so if a business wanted to contract with Mayo, there's nothing that prohibits Mayo from contracting with a business to help them roll out testing. Is that true? I'm reading the contract and I didn't see anything that prohibits other contracts. I just want to be clear. And then I do have a question about dentists and elective procedures. So Mr. Huff, first to the exclusivity, and then to, I'll ask another testing question.
Madam Chair, that is my understanding as well, that there's nothing exclusive in this agreement that would prevent someone else from working with Mayo or the university. To the ambulatory care centers, dental care centers, the first of all, I would ask them to use, what mechanism do you use now? How are people tested now before doing procedures? And if you do not have a, I think an ambulatory care center might have that through their, referral, whatever doctor referred them to the care center. For dentists, obviously, they may not have that. But the goal is that they would be able to, through this agreement, work through the command center to get testing kits so that they can also have their patients tested.
So just to be clear then, dental clinics and ambulatory care centers need to first go to their own testing access, so Quest Diagnostics or a private lab. And then if they can't meet capacity, then they would be able to come to the command center. Is that fair representation, Mr. Huff?
Madam Chair, we are not precluding them from going to the command center first. I just always, I think it's helpful for people to use their standard practices that they're used to. However, the command center will be available for them if they would rather go that route.
Okay. I did have a question. I'm not seeing the commissioner online yet, but I heard you're asking health systems to report their or their sites where tests would be available. Is that a condition of them being able to participate in this center? So for example, if a healthcare system doesn't have current access to enough tests to test their workers, or if they, for example, Genio in Candy, Ojai County, if the care system out there doesn't have enough access to tests already to support reopening food processing plants, are they going to be precluded from participating in this command center if they don't share their public testing availability?
Madam Chair, no, everyone has access to the to working through this contract. Now, we've had great response from folks sharing their data, and that's important because we want to help support. We need to know, what are you missing? You're missing swabs, you're missing reagent. We can help with our supply manager to track that down. We're not precluding people from participating based upon something like that.
And Senator Rosen's hand is back up. Senator Rosen?
Thank you, Madam Chair, and thank you, Mr. Huff. Can you explain how it's going to work with the rural hospitals and their testing and their reimbursement from these insurance claims? How is that process going to do? How's that work with whether they send a test to the University of Mayo or University of Minnesota or Mayo? How is that whole process going to work?
Mr. Huff?
Madam Chair, Senator Rosen, that's one of the questions we have. It's one of the things that we're going to figure out with this structure. Billing and financing obviously is very important. We want to make sure that we're billing insurance appropriately and those costs are getting covered.
Madam Chair.
Senator Rosen.
Thank you, Madam Chair and Mr. Huff. So I guess my question is it the provider's responsibility for the billing, or would it be the Mayo, or does MDH step in? That's the logistics that you haven't quite figured out is, I guess, my question, and probably what you're trying to say too. Is that right?
Mr. Huff?
Madam Chair, Senator Rosen, we're working through that so that the goal is that insurance will make sure that the insurance fully covers, and then we support whatever is not covered, so that the local clinics are not, and the patients are not left holding the bill.
Thank you.
Thank you. Senator Rosen?
No, thank you, Madam Chair.
Thank you. And Mr. Huff, we're going to hop over to Dr. Colleen here shortly. I don't see the commissioner joining us, but I do want to talk a little bit about the contract. You had referenced the HIPAA standard, and I know there are going to be some people nervous about the fact that we're at a HIPAA standard and not the Minnesota Health Records Act standard. But I've asked for some clarification, and so I think we'll have Senate Council get out a memo as to what the privacy protections are for this data, and how having a HIPAA compliant software program or database still has to meet the standards of the Health Records Act and privacy provisions, so that we don't have to. There's been a lot of concern about testing information being available more broadly than perhaps is medically necessary. And so I just wanted to let members know I'm aware of it. If you have concerns and want to raise them with Mr. Huff or either of the commissioners responsible, I understand that and support it, but I'm going to ask for some clarification from Senate Council to make sure that Minnesotans know that they can do voluntary testing and that their records will be respected and kept private, except for specific epidemiological needs already in law. And so I'm going to ask for clarification on the contract for that. If we could, I'm going to shift. I see no more hands for Mr. Huff. Dr. Colleen, I appreciate you on such short notice. And we did offer to the Mayo Clinic, but Dr. Colleen, from your perspective, if you can give us an overview of what this testing structure looks like from the university's perspective.
Well, thank you, Madam Chair. First of all, let me introduce myself. I'm the director of the clinical labs at the East Bank Hospital of the University of Minnesota Medical Center, and I'm the medical school in the Department of Pathology. So to this point, we have been offering the molecular testing, which is testing for the virus in patients. And we have been prioritizing according to the state guidelines, which is patients who are acutely ill, patients in congregate settings, dialysis, and so forth. So one of the earlier questions was about why the volume testing has been relatively low. And in my opinion, at our site, it's because we've been following basically the guidelines and limiting testing offering to sickest patients. In the last week, the state has expanded the criteria of patients to any symptomatic patient. And what we're seeing is in parallel with what Mr. Huff mentioned, which was a ramping up of the number of tests that we're getting on a daily basis for the molecular test. The serologic test, which tests for antibodies and is primarily used to determine if somebody has been previously infected or if they're still susceptible to the disease. We've only been offering that test in the last week or so, and we've had relatively little volume there, as you expect. We think going forward, that's going to be an important test as we look at the community and see who's been infected. And that might have some implications for if when people return to work, what sort of precautions do they need to take and so forth. But those are policy decisions that are sort of not just a lab test result, sort of an issue. For us at the University of Minnesota, working with our partners at the Mayo, this is going to enable us to expand greatly our testing capacity through availability of funds to acquire additional pieces of equipment, supplies, and so forth that we need for this test. So this is really an investment in the state's testing capacity through the university and the Mayo. We do not envision at all that we're going to be the only sites. Of course, that was the case. Places like Hennepin County and Hennepin Healthcare, Alina Health Partners, and so forth, and all of the other hospital systems will continue to do testing. But there will be testing available somewhere in the state, and if it's not at those sites, then the university and or Mayo will be able to accomplish that. That's how I see this. It's a guarantee to the state that there will be testing for patients available. And it's a very significant development, certainly for our lab, to get this additional equipment so we can expand our offering of testing. Additionally, there are, as you might expect at the university and at Mayo, there are academic and epidemiologic interests at heart here as well. We want to understand this disease. We want to understand what's the way to manage the outbreak, starting with how many people in the state have been infected. You were showing a graph earlier about the numbers. We look like we're relatively low, but that could change obviously as time goes on. So these are critical things for us as Minnesotans and as state and university to understand this from a public health point of view as well. So it's not just the testing, it's also the public health aspects. So I don't know, Madam Chair, if that answers your question.
I just appreciate, we hear from MDH regularly, hearing how things move on the implementer side in partnership. So members, any questions for Dr. Colleen and how things are going to roll out on the testing center side, not the MDH managed side? I'm waiting. I see Senator Rosen's unmuted. Did you have a question, Senator Rosen?
Yes, thank
Rosen.
you, Madam Chair. And Dr. Kleen, are you doing active testing outside of Minnesota also? Are tests coming in from other states?
Senator, we at the university are not. I can't speak for the Mayo Clinic because they're a national reference lab, as you probably know, and they may be doing some testing for clients who are outside Minnesota, but we at the university are not.
And Madam Chair.
Senator Rosen.
Thank you, Madam Chair and Dr. Kleen. Is your methodology or your testing capabilities, are they brand new? Is this new technology or science? Because you mentioned new equipment that's going to be purchased with some of these dollars. So is this you're rolling out all new testing, or is this some of the testing? A lot of questions in this, a lot of variables in this question I'm asking, but is this all brand new science that you're unveiling? Dr.
Kling.
Well, Madam Chair and Senator Rosen, so of course, as you know, the virus has only been known to us for a few months, so that aspect of it, of course, is new. The testing that we brought up initially was what we call developed tests. So this is based on principles that we developed in our own laboratories. We've also acquired equipment from commercial vendors, notably Sorin, which has a presence here in Minnesota, and Cepheid, which is based in California. So for the molecular testing, we're running a combination of assays that we've developed ourselves and commercial assays. The assay that we developed ourselves was submitted for approval to the Food and Drug Administration, as was required under federal guidance. As I'm sure you know, clinical labs operate under very strict federal laws. And we complied, of course, with those in notifying the FDA and the data. We had a letter, I think it was earlier this week or late last week, back from the FDA saying that they had changed since we submitted the EUA, Emergency Use Authorization application. They had changed their own regulations and it was no longer required to get an EUA. We were allowed to continue doing testing, but our intent is to pursue the EUA application in any event. So yes, it is new testing because it's a new virus, new to us, known to us. But we are using both lab developed tests and commercial assays. Does that answer your question, Senator Rosen?
Senator Rosen, thank you. Thank you. Members, we do have the contract in front of us, and there is some intellectual property rights pieces in there disclosing who owns the research and who owns the results. It's beyond the purview of this committee, but if you have questions, reading those paragraphs will give you more questions, has been my experience since I saw the contract. And so, Dr. Colleen, I want to thank you very much. Mr. Huff, we expect Commissioner Franz to join us about 12:15, and that gives the committee a little bit of time to start looking at what phase 2 is. So we've started to have some descriptions of phase 1, $36 million going to 2 entities, a coordinated procurement process, it sounds like, and then a rollout to hotspots and specific priority populations for the purposes of improving our understanding of public health. If you could tell us about what phase 2 is starting to look like, because it's my understanding you're going to come back to the legislature with some specific requests, or there will be another level of engagement. But I know phase 2 conversations have started. Are you comfortable sharing those with us?
Madam Chair, I'm comfortable sharing, although I don't have much to share, more than the concept at this point. So, you know, we are just literally figuring out the structure of all of this and how we're going to move forward. By next week, I hope to have a lot more definition to be able to answer your question. But right now, I don't have anything in my brain to tell you.
And I had heard yesterday, particularly about the testing, contact tracing, the number of people you're going to need. Can you walk us through some of that decision making? We heard the number 500 people. Will they be temporary employees? So how did you come up with 500, and what kind of work will they be doing?
Madam Chair, so again, this is a preliminary estimate, but I'll tell you how I came up with the number and how we're going to be trying to find more definition of that. So a contact tracer, the job is we do an interview for anyone that is come back with a positive test, and that person then needs to be in isolation until they're no longer infected with the disease. But we ask them, who have they been in close contact with, so that we know who they might have shared the disease with. And then we follow up with all those contacts. We see if they have symptoms. If they have symptoms, then we hook them up to make sure they go to their clinic and get tested. And if they don't, then they need to quarantine. Either way, they have to quarantine. And quarantine takes 14 days if you're asymptomatic during that time. And the reason it's 14 days is that is what we believe is takes to run the course of the disease, that if you were to have symptoms, you would have had them within that 14-day period. And then we know you need to stay home even longer. So what we estimate is a contact tracer can conduct interviews of 4 to 6 people a day. These are not just quick phone calls. There's a lot of questions with these phone calls. You're telling someone that they have been in contact with someone who tested positive for COVID. So that can be an emotionally difficult phone call to have with folks. There are a lot of questions that people have. And then there has to be a thorough interview. We talk to them about what they need to do. And then we ask, well, what do you need to be able to do that? So do you have access to your healthcare, to your medications? Do you have a way to get food? If not, we work with local public health to provide and make sure that those wraparound services are provided. So, you know, we don't want someone to sit in quarantine and not be able to eat or get their medication. The way we figured this out is, so if we have, we're aiming for an estimated 20,000 people tested a day. If it takes, if we have a 10% positivity rate, that gives us 2,000 people a day that are positive. And if we say that one person can test 4 people or call 4 people a day, then that would mean we'd need 500 people to call those 2,000 people a day.
And Mr. Huff, those will be temporary employees. How will you source them? What are the criteria?
Right. So we want folks that there's definitely some soft skills that are needed here. It's sensitive information, and we want to make sure that people are compassionate and understanding and good on the phone. The hard skills is we do want a background, at least a basic understanding of the disease, of public health. Um, and so there'll be some, now obviously we'll be doing training for folks, but we do need to have some technical background. We're looking at sourcing folks in the following ways. One, what other staff within MDH can be redeployed to this? Using students at the School of Public Health, and utilizing our colleagues in local public health who are trained in public health. And if we have to go beyond that, then the next step would be reallocating other state employees that may be furloughed, and if necessary, doing posting temporary positions. I don't think we'll need to get there because we have a really deep bench with those 4 different categories that I just mentioned.
And Mr. Huff, could I throw out there, we have nursing students who can't be licensed because they can't get the testing. There are limited testing sites. Think about putting them on your list as well. I mean, they will have graduated, completed their clinicals. They can absolutely understand the disease. And because we don't have exceptions to licensing in place, they might be able to be hired as CNAs, but they can't be RNs. So they might be a good additional resource. With all due respect, I guess I'd rather have a nursing student than somebody who was redeployed from Department of Public Safety, perhaps something. So I thought about adding that to your list. Senator Rosen and then Senator Klein.
Thank you, Madam Chair. And Mr. Huff, also have you thought about some of the nursing medical staff that's been furloughed in greater Minnesota? They could use a job. They are sitting at home when we have, and they are desperate for a job too right now, especially in my area.
Mr. Huff?
Madam Chair, Senator Rosen, great point to raise. Thank you.
Thank you.
And definitely bring that back to our team. Thank you.
Thanks. And Senator Klein.
Thank you, Madam Chair and Mr. Huff. And I'm making the same point that Senator Rosen and yourself have made, that we have a huge sidelined and well-trained medical workforce right now that could do this pretty well. And in fact, physicians, infectious disease physicians at the Mayo have reached out to me, saying that they have sort of a large training workforce that would do good contact tracing. And I can forward those emails and contacts to you. I think we have a pretty good workforce in Minnesota to do this expertly.
So, Senator Klein, I appreciate that. That's one of the reasons I like to bring these things to public, because we have really smart people on this committee who have good broad context and hear different stories than what might be heard in the agency. So we can build a better program. Senator Klein, your hand is still up. Okay, thank you. Mr. Huff, so this first phase, we anticipate being launched in 3 weeks or fully implemented in 3 weeks. And then phase 2, when would we expect that to have deliverables, and how long will each of these phases last?
Madam Chair, so our goal is to have, and per the contract, this first phase needs to be up and running within 3 weeks. We're working simultaneously to begin ramping up those next phases as well. And this, I anticipate this running until we are out of the woods with COVID. We're in this for the long haul. This is going to be a 12 to 18 month journey, unfortunately, to get us down this mountain. And we want to do everything we can to make sure that we arrive down the mountain safely. And testing is an important part of that.
Okay, and I see Senator Corinne's hand is up as well, but I did ask about phase 2. When do you anticipate that being launched, and that extending for the 12 to 18 months as well. So when would be a date the public could expect to see phase 2 ready?
Madam Chair, I can't give you a date right now, but know that we're beginning working on it right now.
Okay, and to the extent you can include any and all members of this committee. I know planning by committee is a difficult process, but we do have smart people who genuinely care about getting this done right, and they can add value. Senator Curran. Oh, Senator Curran, did you have a question? And you're on mute, Senator Curran.
Madam Chair, I did have a question and then I didn't. But the question I have is, and I think you brought up multiple times, is I have a dental clinic in my district who appears to be serving most of northern Minnesota. They've taken a couple hundred patients already. They don't appear to receive any recognition or even acknowledgement that these offices are existing. They're frontline. They're serving, again, hundreds of people that the emergency rooms won't, and or the other dental clinics who have completely closed up shop. The stories that you hear, and Senator Benson's done a good job at mentioning, they have a bunch of high-risk people in addition to the emergency people they're seeing today. They have to get them open. We have to figure out a way to, one, to get them the equipment they need. Right now, they haven't received a single notification, been included in anything that would treat them as a frontline medical staff fighting the battle that everyone else is. So they're looking for the agencies to include them, make available the equipment that the personal protection equipment that they need, and also allow them to open up to see the high-risk patients. Gum disease and all of those things where they have to have high maintenance and routine maintenance, there will not be any room in their healthcare system or their clinics to see them. You can't have 3 months worth of backlog in high-risk clients and then expect them to get in any time soon. So we're seeing a significant number of those issues, and we need somebody to address that. It certainly would be nice if the Department of Health would acknowledge it and then reach out to all of the dental clinics, especially those that are truly, they're frontline emergency rooms. So with that, we'd like to see some action and something to reach out and include them in every aspect of the frontline healthcare workers. They are today, they're doing the work.
Mr. Huff, a response?
Madam Chair, Senator, thank you for raising that, and I think you're right. There are many parts to health beyond just COVID, and we have people that are in great pain because they're not able to access surgery. We have people that have significant conditions, as you said, that we need our dentists to be able to perform. So I agree 100% that we want to make sure that people are able to get the healthcare they need. And so I think you raised an excellent point, and I'll bring that back to our supply team to make sure that we are connecting with these our dentists that are performing this urgent and necessary care. Thank you.
And I see Lisa's on the call. Maybe we can coordinate. I've had some questions about appropriate protective equipment for dentists and other non-hospital providers. And now that the testing is going to be more centrally available, some guidelines for them as to how they need to source their own PPE, their own testing, but there is a backup plan as they make plans to reopen. So let's make sure we're coordinating between MDH and the health boards. I'll take that as a committee follow-up. So thank you, Mr. Huff. I see Commissioner Franz is with us. Welcome to the committee, Commissioner. We did get a copy of the executed contract, but we'd appreciate your perspective from MDH on where the money is coming from, what it's going to be used for, et cetera.
Good. Well, thank you, Madam Chair. Glad to join you. Appreciate the opportunity to talk about it. So as you know, the contract has an exhibit to it, and the contract provides for the proposal for this phase 1. And I think I do want to start with the big picture. This is everyone clearly understands this is phase one. Phase two is actually begins today with these discussions and more about what do we do next. The goal was to, as quickly as possible, stand up this capability for the testing with the combination of Mayo and the University of Minnesota. And so the deliverables that we established in the contract were designed to be somewhat flexible, to be honest, because one of the things we added to the contract, let me just sort of start there. This is on Exhibit A, page 1 to the contract. And it talks, there's a paragraph there that I think is important to talk about. This the sort of the third paragraph down right before proposal phase one starts. It says this proposal contains both a framework for collaboration between UMN and Mayo Clinic and specific goals to be achieved through the collaboration. It is important to emphasize that these are meant to be adaptable, to develop, to reflect changes in knowledge and understanding of the COVID-19 pandemic, and to changes in developments that may affect Minnesota. These changes may necessitate reallocation of resources and reprioritization of goals to maximize the benefit of the collaboration and the benefits to the state. So it's a little bit of an unusual document in that regard. The quick nature of this, the short-term nature of this, and yet clearly the focus obviously was testing, providing the testing mechanism, the command center, developing hotspot testing, providing a cost and a delivery system. It was clear we knew what were the basics of getting. We wanted to get stood up right away, but we frankly are working now on what are some of those things look like, which we'll be talking to you about in terms of what we think that system looks like, and how should it go forward, and how should it be funded going forward, which are questions we need to talk to you all about. Anything else in particular that you'd like me to go through, Madam Chair?
Well, and we do have the finance chair here. I know we've talked about the likelihood that this is federally funded, and are we intentional about designing phase two to make sure that we can use that federal money as a priority? I know the governor's COVID fund has money in it. I'm not saying we shouldn't do things if they're not covered by federal money, but using other people's money first seems to be a wise approach.
Madam Chair, I like that perspective always. I know, and I think in this particular case, when you looked at I saw the guidance that came out on Monday in advance of the new legislation for the $25 billion for testing around the country. Obviously, a lot of that goes to the federal government. When I was looking at the example of the language in that reimbursement for testing, it was very expansive. And so what we did, we continually had an eye toward, let's make sure, we need to do what we think we need to do, but on the other hand, we believe most, if not all of this, will be reimbursable under the principles established by the testing protocol. And no, we can think about it though. If we are right and primarily, then we're going to get to use this money again. And that was our goal, was to use the Minnesota fund out of the $200 million original fund, to use that money to get this program, to stand it up in essence, almost like seed money, but then to make sure that whatever we can do, and we have an agreement, there's a paragraph in here about reimbursement where we ask all the parties, the plans, the hospital systems, the Mayo, all of us all agree that we will coordinate to make sure that all the parties get reimbursed to the maximum extent possible under law. And I don't know how quickly that's going to happen, Madam Chair. And we'll see, these things never work really very quickly, it seems like. But the goal is, if we're right, and if we can get this process working correctly, then we'll be able to seek reimbursements and then use this money again for some other COVID-related expenditures.
Thank you, Commissioner Franson. I'm not seeing any hands up, and so you were gracious enough to hop on a little earlier than you planned. So not seeing any hands. Just want to ask, Finance Chair raised her hand. But I do, before you close out, I know we're supposed to be getting a budget update. This committee has a pretty big budget. Before you leave, if you could give us a heads up on what day and what we can expect. So Senator Rosen, your question.
Thank you, Madam Chair. Good morning, Commissioner France. Actually, afternoon. Good to see you.
Good
Uh,
afternoon,
two,
yeah.
two quick questions. I'm looking at the reporting that is in the contract, a monthly report, itemized report that would it would be interesting to see what is going to be required in that reporting. And the second question is, I think on the back of the napkin, we've spent about 112, 115 million out of the governor's 200 million. Is phase 2 going to blow the rest of that money? We've been asking questions all morning about and Madam Chair has been asking questions about what is phase 2 going to look like, and are we expecting to have to supplant more money out of the general fund for that phase 2, above and beyond what is in the governor's remaining amount?
Madam Chair, good.
Commissioner Franz.
Right. Yeah, thank you, Madam Chair. Good question. And, I think that this actually gets to what we talked a little bit earlier in the Senate Finance earlier this week. So we're going to have that day of that we'll release a budget projection, I think, on Monday. But it's going to be that first full week of May, and at that time we will assess the revenue in terms of what we anticipate is going to happen to the state budget, and look at some of the expenditures that we've had to incur, and then what may or may not be reimbursable. So we're going to give I think at that point, we'll give the legislature what we think is the best view we can have in May for us to make decisions in May that I frankly don't think will end up being the last decisions we make together about this budget. Anyway, so that's what we're trying to do here. Now, in terms of what Chair Rosen was talking about, this is the other balancing act that we have to do. At the same time that we're managing the state general funds, we have to take a look at the stream of revenue that's coming in from the federal government. It's a little over about $3.2 billion, 2.1 billion, almost 2.2 billion of that is coming in that one chunk, as we've talked about, for the states, about 1.2 billion, and then the rest for the local units of government. But we want to present to you sometime next week our view, and I know your staff has some views too, but our view of how that money can be used, where it can be used, and how should we use that in conjunction with the state money that we're currently using. So the decision point that we're going to have for phase 2, that collectively we're going to have to decide is what should the agreement be going forward? What do we want to fund? What do we think makes sense? And do we have a better sense of what reimbursement looks like? But we also need to decide where to point those dollars from. Do we want to use the Minnesota fund, or do we want to use some of the money that's come from the federal government, the $1.2 billion? Maybe that's one of the ways that we can collectively work on pointing that money to this particular endeavor. I think that, one of the things we're going to learn it day by day and week by week through this process, which will help inform us over the next week or so about phase 2. What are those things that we need ongoing funding for, and where do we want to put that money? Is it in the command center structure to oversee the transportation process, obviously the testing costs? So there are a lot of variables into that. I think that we could certainly use the Minnesota fund if necessary. And I don't know what the status of that will be in another week or so. I mean, we're continuing to find more and more PPE that we need. We're clearly behind on PPE. We all know that. But we also have some alternative sites for healthcare, for treatment that we're trying to lock down to, which are really more expensive kind of pieces of things. So I'm not answering your question very well, I think, but I think it's because it's a whole bunch of factors that we all need to collectively keep in our minds about general fund, restricting our general fund exposure because it's going to not look as good as we'd like it to in May. And then how do we use the federal funds most effectively, and what do we think we'll get reimbursed for if we do use FEMA funding, for example, in some cases. That was kind of a long-winded, I don't know, I think. If I get to the bottom of my answer, I'm sorry.
Thank you. And Senator Abler?
Well, thanks. I didn't know how long the line was. And I appreciate Commissioner Franz being there and And we're kind of moving into the budget discussion, which I cannot wait to have more of these. And I appreciate your optimism where you mentioned that the forecast may not be what you're liking. And I hope that's an overstatement. Like, oh, it's going to be great, but we all know it's going to be just devastating. Could you comment, please, about a group that's especially challenged in trying to rejoin their ability to work, which is the small shops that are really like sole proprietors, those little antique stores and whatever stores they have, shoe stores that cannot open and have almost no funding available to support them. And I've been told the governor is thinking about this, and I know you're part of those discussions. So could you kind of just outline what you're thinking is going to be their future? I know they could accommodate to all those CDC guidelines, and they're very small and have incidental traffic there. So could you please comment about that from what the administration and you were thinking?
Sure, I'd be
Commissioner
glad to. I
Fran?
think you really, Madam Chair and Senator, I think you really hit on a really important issue. The goal is really to, with this testing and providing a really robust testing process throughout the state, it's going to help us be more, have more data about where the hotspots are and what we need to watch. And the idea with bringing people back to work is really doing it safely. So a safe return to work. And as you suggest, there are a lot of opportunities for people to do that. We're working on the same thing in terms of some of the state work sites to make sure that as we bring some of our people back, although we're going to continue to focus on teleworking, but when we do have to bring some people back to the work site, we have this sort of the same issues that the local small business owners have. And that is in small areas, you can practice in small shops, you can practice social distancing, and you can also maintain some pretty good, safe standards, and whether it's wearing a mask or some testing or temperature testing, screening, I should say. So I think the goal for us is to open up. As we open up, we want to make sure we do it as informed as we can be. And so we don't open up too fast, but yet we provide opportunities for people to say, you know what, I can do this business safely. And here's how I go about doing it. And so that's part of what Commissioner Grove was talking about yesterday on this idea of businesses able to certify that they will maintain these safe standards by the CDC and the Department of Health. So the goal, frankly, is to be careful, to realize we still have the stay-at-home order in place, but to figure out ways that we can slowly and safely reignite this economy and get people back to work.
Well, and Madam Chair and Commissioner, if I can just go a little bit further. I mean, what you really said was what I would hope you'd say, but there's really no substance to it. I mean, these people, like, let me just give you an example. A sole proprietor runs a shoe store, and there's one person working in there. They're the manager, the supervisor, and the employee, and they have 2 people an hour in there now. They are intrinsically a low risk site to start with, that they could even improve upon that. And I don't know why there's a delay in letting them work when we're letting factories and other places go that actually have far more risk and interactions to deal with. So I'm not here to badger you. I'm just like, these folks are desperate. They have no reserves. They burned through them. They made April's rent. They don't know how they're going to make May's rent. And whatever unemployment they can get is still backlogged, and nothing is coming in their door. So, and I know you're aware of this, but what can you say that's got some concreteness to when they should open? It seems to me they should not be delayed even at this point. So can you comment, please?
I actually cannot on the timeline. I mean, actually, Dan might be able to, he may be more aware, Mr. Huff may be more aware of sort of the process we have in place. I don't have that exact timeline in front of me. I don't know if you do, Dan.
You understand my question, though?
Yeah, I do.
Yes.
Thank you very much.
And Senator Rosen?
Thank
that
you.
point.
Yes, thank you, Madam Chair. To that point, and Senator Abel has been a very strong voice. We all have for small businesses, but I think Commissioner Franz, you have a very strong voice with the governor. And just being in the Vernon Center post office the other day, as you can imagine, it's a small little post office, and it's clearly posted on the outside, only 2 people in the lobby at one time. And I think we've underestimated the ability of these small businesses to figure out how to appropriately do safe distancing and take care of their patrons and themselves. And I think we need to fast track this. And at some point, I'd like to talk about ag also, but I'm not going to do it in the same breath. And Commissioner France, you mentioned something about telecommuting and how to continue it. I am going to be dropping a bill shortly once it's comes back from the reviser to allow what we have, what the governor has in place, what's in place to continue after the emergency declaration is over. I think that's very smart. Haven't talked to the health plans yet, but I think we've shown that telecommuting and telehealth, all of the above, is successful and is working very well. So we should continue with that measure, I believe. And I'm looking forward to the discussion, Madam Chair.
Thank you. And I want to be respectful of everybody's time. So I'll let you know who's on the list. And I'm going to let Commissioner Franz go in 4 minutes. So make sure you're to the point. Senator Hayden, Senator Kiffmeyer.
Well, good. Well, thank you, Madam Chair. Thank you, Commissioner Franz, for being here. I really appreciate the persistence of Senator Abler's comments about opening up small business and others. I have plenty of small businesses in my district and micro businesses and malls that are hurting as well. But I do want to remind members, we were on a call, I think Senator Kiffmeyer mentioned she was on it, Hennepin County members. We're still headed to the surge. Hennepin County's numbers are up exponentially in potential presumed, confirmed and presumed COVID cases. This virus is, there. We have hotspots. To Senator Rosen's point, we do have to have an ag conversation because I'm not an ag expert at all, but I'm hearing about the pork processing plants and other processing plants being closed because of the virus and having to euthanize livestock because there's no place for them to be processed. And there's a burgeoning problem, and I'm really getting in deep water here, Senator Rosen, about how to deal with that the livestock that have to be euthanized because the processing plants are closed. So I feel the passion. We all do. Senator Abler, I imagine, is on a campaign. I've heard about this about 2 straight weeks and appreciate it. I think it's important. But I do want to remind members, and I'm glad that Assistant Commissioner Huff and Mr. Franz and others, that we still have issues, major issues. Businesses are smart, but this virus sometimes gets around even the smartest of social distancing and practices. So I don't want that to be lost in the process of having this conversation that we should open up Minnesota without doing the things that we want, or just simple logic, layman's logic that I just tried to apply on the ag becomes the theme, if you will, or the backdrop to what we should do. I would hope that we would continue to work with the scientists, public health professionals, and the really smart members of this committee to continue to do the right thing. So I just wanted to make that comment as a way to, not say that we shouldn't open up small business, but we should proceed cautiously. We're just headed into this storm.
Thank you, Senator Hayden. And it sounded like there wasn't a question there, but Senator Kiffmeyer does have a question, and Commissioner Franz is done at 12:30. He is a busy man. So, Senator Kiffmeyer.
Thank you, Madam Chair. I do want to comment. The virus was never anticipated that it would disappear or go away. Because we flatten the curve, it just means that we're going to have a higher gradual exposure when we come out of this phase, but such that the healthcare system can handle it. And not all parts of Minnesota are equal. I think we should give special attention to Senator Hayden's district and deal with those things without question, but as we should also do in cities like Anoka, Big Lake, and others in rural Minnesota, not treat them as if they're all the same. But Commissioner Franz, I had a hearing yesterday with the cosmetology board. Currently, the governor is not allowing curbside pickup like for all restaurants and a whole variety of things. So Commissioner, can you respond as to why we have this situation where privately owned salons or barbershops can't have curbside pickup for products? It just seemed like it doesn't fit, and it would be perfectly safe in the times we are in right now.
Senator Kiffmeyer, or I'm sorry, Commissioner
Commissioner
Franz.
Franz.
Hey, I always wanted to be a senator. Thank you. I don't know the answer to your question. I think that part of the thing when we started doing, remember, about 82% of the economy has been deemed essential, and that doesn't sound very good to those who are not in that group, right? I understand that, and I think the issue was as we start working on bringing those folks back, the goal was more on letting them open in general. But I think one of the questions you make a good point of, all these salons, they have both the professional service, but they also have the retail component to what they do. So I don't know the exact reason why that part hasn't been brought back, but I certainly will take that concern that you mentioned. I understand the concern.
Thank you.
Yeah, thank you, Madam Chair. I just want to clarify again, this was not about giving haircuts or services or things like that. This was about the products that they could go into Walmart and shop there and be next to each other in a much less way. So doing this product at curbside just seems to make sense. Thank you, Commissioner. I appreciate your checking into it. And could you just get back to me and let me know the status when you can?
Thank
We'll do that. Given my haircut, they could actually do my haircut on a drive-by.
I am the barber in my house.
So am I in mine.
Okay.
And Commissioner Franz, you've been so generous with your time. Thank you. And we know the governor yesterday rolled out a strategy for opening businesses that didn't require testing. And that is good news, because that way testing is not the restricting factor in a business opening up. Businesses can start making a plan without having to be tested. But we know that more testing is going to build confidence in Minnesotans, so they'll go out and re-engage, and that's going to help get our economy going. So those two things working together are going to be really important to get our economy going. The governor's plan to let businesses open in a thoughtful, safe way, and then the testing that's going to build confidence. And so thank you, Commissioner. I know you are a key person in all those meetings and had a hand in that strategy along with Commissioners Grove and Malcolm. So thank you for being here and informing our committee, and we'll see you in finance probably. Thank you for your time today.
Thank you so much. Goodbye. Take care.
Thank you. And we have people from MDH who have other places they need to be. So I don't see any further hands raised. Senator Nelson, you had your hand up for comments. Briefly, Senator Nelson, and then we're going to adjourn.
Yes, thank you. Just briefly, I wanted to get back to some of the questions that I heard earlier on today, and just provide some information. I thought I heard the question about, how much testing is happening right now. Starting now, there's 1,000 serologic and 2,000 molecular tests daily. There is more capacity than that, but this is how some of the decisions were made to start at this amount. 1,000 serological, 2,000 molecular tests a day. And then I think I heard someone have a question on the cost as well. And you could Google this yourself, but I'll just put it out there. The basic charge price is $99. That's listed publicly on the CMS website. But of course, the tests are being offered to the state for a much lower rate, as we would expect. And those prices are $62 for the molecular test and $33 for the serologic test. So you can see it's a greatly discounted rate. And I think we should be really rejoicing in that we live here in Minnesota, because we have the ability to not only procure, but provide this really massive testing access that just doesn't exist in a number of other states. So I just wanted to provide a little bit more clarity to that discussion that we had earlier.
Yep.
So the confirmed price is $62 and $33 for the tests.
So thank you, Senator Nelson. Members, I don't see anyone else's hands up. Thank you for your time and attention today. As soon as I hear something about phase 2, we're going to start participating. Oh, I see Senator Hayden waving his hand. All right, Senator Hayden.
I'm just saying goodbye. I'm just saying sayonara.
Oh, saying goodbye. All right, everybody. Thank you. And with that, we are adjourned.